I'd like to call Dr. Abath. Dr. Abath is one of the titans of radiology. He doesn't need to be introduced here in Brazil. He educates professionals, and Abath is going to talk about his experience in the first angio suite in Brazil. Thank you. And our equipment, we owe to three people. Dr. Harai, of course, who developed the technology. Then my friend Zé Hugo, because he told me this story before you. He told me this in 2019, and I trusted his professionalism. I started this project. And also Thiago, who participated in the negotiation. So I'm going to show how our life changed in the group, and I think it changed a lot. So first of all, I'd like to show you how this changed and who we are. So we are the interventionist group. We are multidisciplinary. We all work with the interventions. We have radiosurgeons, neurosurgeons, and vascular surgeons. This is our team in the picture. And we do a lot of interventions. There's biopsies, catheters, even the most complex ones. And then we also do visceral radiology oncological intervention. So for neurointervention and vascular surgery, we basically use an angiographer. But for visceral and oncological interventions, we use the angiography and the ultrasound and the CT scan. But this was done in another sector. So we installed this in the Portuguese private hospital. It is the greatest emergency hospital in the region. And we have 3 rooms of angiography. We have one hybrid room, which is really what changed our practice a lot. It changes a lot. And then we have 5 MRI devices and CT scans. Now, our routine in this hospital, the routine was the following. We did the vascular interventions and the hemodynamics and angioplasty, stent, embolization, and the non-vascular procedures we did with the imaging sector that allowed us to use the room as from 7 p.m. until midnight. And then we did the stent implants and all the different surgeries. So this division in my mind was always very superficial. And when Zé Hugo, he also reinforced this in my concept. And then we learned about this special ideal environment where you can do interventional radiology in all its aspects. So this is a CT scan and an angiography, an angiographer, and the images pass on to the screen, and they are superimposed on the screen. And our resident, Isabella over here, our model, she now lives in Rio. So what changed in our flow of work? So in terms of the flow, the first thing is that we were able to get a complex room, and there has to be a radiologist to know how to use it. And today we have an exclusive room for interventions and without sharing with cardiology, without sharing with vascular surgery. And this was a huge organizational change, and we have to be inside the diagnosis. We don't have to go to diagnosis and go back to hemodynamics. We can do it together. When urgencies come up, we're always able to accelerate the entrance of the patient in the room. It optimizes our time. It concentrates our procedures during the day, because we used to do a lot of things at night because we didn't have the radiology department available. And it's our own pharmacy, which is a great disadvantage in terms of imaging, because you don't have the catheters. You have to take that kit, and if it's different from what was planned, you have to get it in another sector, and that takes a century. So what changes also human resources. That's a great advance as well. So Hugo also talked about that. We have a group from anesthetics working in hemodynamics. They work with resuscitation of patients and all of that. And in radiology, it's a little lighter. So the conditions, at least in our hospital, working with anesthesia. So and most of them come from tomography, and there is an impact. And Then we also have enabled technicians, people who know how to deal with angiographies and CT scans, and also nursing that is trained for urgency. So that's the big difference. And what about the safety in the processes? We know that an intervention, even if it's very simple with a biopsy, it is subject to a complication. And when you complicate this in imaging, it is very serious because you're going to have to transfer to another sector. So with this room, we're able to identify the complication. If it's vascular, if it is the non-vascular procedure, then we're able to solve this immediately and not having to transfer the patient to another sector. And the control done in the CT scan, this is non-vascular, and you can see the bleeding, active bleeding, and this patient, did not have to waste time bleeding and go to another sector. So this was identified, and this was an adrenal artery. It was embolized and directly controlled the situation. And then prophylaxis of the complications. So there was a 4-year-old child, lytic complication in C1. And normally who does this is the biopsy, and then the problem is getting the vertebral artery. You have the guided biopsy with fluoro-CT, and we saw there was a dissection, and we decided to close this on the left to avoid thromboembolic complications. And this is from Singapore, showing the time that you waste there, and it's even more time in our case, between transferring from CT scan to angiography or vice versa. It's about 45 minutes to 1 hour for the transfer. And with this hybrid equipment, it takes you, from one to the other, it takes 5 minutes maximum. So definitely an advantage. Right? It's obvious. And the gain in efficacy and resolution and safety. This is another case. This is a patient that had done an ablation. And in these cases nowadays, we always start with angio, but we don't do the normal angiography or a CT scan. We always start with catheterism and intraarterial, and we're using 15 ml of contrast. Over here, we did the ablation. This patient evolved after 1 month with a suspicion of an abscess. He went to drain the abscess. And before draining, we decided to inject the contrast, and that changed our practice immediately. And then we did the angiography, and then we confirmed with pseudoaneurysm in this segmental artery. We did catheterism and embolization with glue. We controlled the bleeding. And then without the chance of, safety, imagine draining this lesion without noticing that there was a pseudoaneurysm. He was going to bleed a lot. And he also developed a biliary cyst in the same segment of the artery, and this was catheterized and embolized later on. And finally, there was a cure of the tumor and no sequel in the biliary aspect or any other. So there's another sector that I want to call your attention to. It's medical emergencies. So medical emergencies, the advantages are obvious. So you have a diagnosis and intervention at the same time, and when it is a huge suspicion, the patient goes to the room directly without any previous imaging. And there are several polytraumatisms, for example, thromboembolism, massive thromboembolism. That's what you have to really salvage the patient. And a volume of bleeding that is very big, and an aneurysm, right? A contained aneurysm, because it's very difficult to get to hemodynamics in these cases. And in the stroke, but this is not very interesting for this presentation. So you do the diagnosis of a large thrombus, you do the thrombectomy, you just solve the thrombus and without wasting time for the patient. And this is the rupture of the aneurysm of the aorta. We measure in the room, and we solve this case immediately in the same hemodynamic room, and we do the diagnosis and treatment. And digestive bleeding, we don't do all of them. I decided to do a protocol with that, but there was great resistance from the rest of the team because nobody would stop, right? So they were right. But the bleeding where the patient is at risk. And this was one case. This patient had a huge aneurysm, well known. And the first suspicion was the rupture of the aorta with a digestive fistula and chronic pancreatitis. So when we did the CT CT scan. So there was an aneurysm, and the diagnosis apparently was more evident over here, not responsible for the bleeding. The bleeding was with this pancreatic cyst, the pancreatitis over here. So we changed our practice, and we immediately forgot that in a frail patient, and he had an aneurysm. We located the bleeding in the geography. We embolized this lesion, and we controlled the problem. This is at the end showing that what was done. This is the control. There was no more hemorrhage. And over here, proving the diagnosis. And you have the contrast here in the loop in a delayed fashion. So what did we change with regard to the protocols? So according to what was said, there was a lot of difficulty in the technical area and developing protocols with intra-arterial angiography. And also for the liver, we do other things as well. There was no reference in literature. So we wasted a lot of time with that. But today, we're trying to change our hospital protocols, our protocols based on our experience until now. So today, we have the prompt response to thromboembolism, and we want to definitely treat patients who have massive thromboembolism. They go straight to our sector, and in the stable aneurysms, it's also the same condition, and the very severe digestive bleedings, and also the way that we conduct chemoembolization. That changed completely, and this is based on what Zé Hugo showed. We don't do classic angiography anymore. We do an angio-CT scan, arterial angio-CT, and we've been using this more to guide ablation therapy, and I'm going to show you how this is done. Also associating ablation with embolization at the same time, and there is a learning curve also in terms of the pathology, and also trying to find new applications for this room as well. So I'm going to show you part of this, and we do the text with angio-CT that is intra-arterial, and in literature this shows it is shown in 60% of the cases. It impacts 19% of the cases, of the practice in the cases. And doing radioembolization today, we have a very small volume of that. It's like 3 or 4 cases only. But then you're able to identify and compartmentalize the lesion and what is the dose that you're going to use in terms of radioembolization. So it's very promising for those who do radioembolization. And here in Brazil, I think Einstein does it. They are one of the most active, definitely the most active. And angio-CT, this is from literature, and you can do the arterial CT, or you could do a portography as well. And it has been proved that it has greater sensitivity for selective contrast injection. It is superior to diffusion and CT scans, and in nodules below 1 centimeter, above 2 centimeters, there's no relevance. And you're able to see the feeding branches, and you can also fuse images to make ablations easier. So this is an example. This is a female patient. This is her MRI. It's a multinodular disease, a very focal HCC. This is the image, and injecting in the celiac trunk, and you can see that over here it's not close to the aorta. It was not a venous injection. It was intra-arterial, 16 ml, and you can identify small nodules that you did not see in the MRI. And something else that is very important, Hugo also talked about this in the main things. In chemoembolization, many times you don't see the nodule. The nodule is hypervascular and you don't see the small nodules, but you can do an extensive chemoembolization, get you get the wrong place as well. This is a super selective case, and then you do the angio-CT. With a catheter, we take 5 ml. That's very little, and it's very fast. And then you get this image. So here you have a patient, and this was an MRI. We knew there were 2 nodules. We thought that this segment was responsible, but now, when we did the CT scan, there's no tumor, so this is a normal segment. And we change the position of the catheter, and then we identify that, in fact, the 2 nodules are well identified, and at the end, we do an ablation. Without contrast, showing retention of the particles over here. And at this point, you can actually do the ablation that is associated or not. So that's very interesting. And then in combined therapies, and this is to eliminate the effect, radiation effect, and you can associate the ablation in the same series, and then you can do chemoembolization. So you have the time and resources that you're saving. I'm not going to go into the details here, but this is the arteriography with chemoembolization followed by ablation, percutaneous and with fluorine CT, and this is the end, the association. And where does the intra-arterial angio-TC look at? So we go to ablation. So we know that in the cirrhotic liver, it's very difficult to do an ultrasound. It's very difficult technically to visualize the nodule, and it's very difficult to know its limit as well for you to calculate your ablation margin, your safety margin. So, and we also have nodules that you do not identify. So there's a quick lavage and you're not able to do the puncture because you see in the arterial phase, when you prepare to put the needle in, you don't see it anymore in the fluoroscopy. So it's a super selective catheter that we use, and we inject 5 ml of contrast, iodated contrast once again, and then you increase the resolution of the contrast, and you also have less tumor recurrence, and you can associate it to embolization, as I said. This is an example over here, not in the territory of the liver. This is more renal. So this is a recent case about a month ago. It was an elderly patient, and it was conservative, and the tumor grew, and there was a limiting renal function, and this technique that makes it easier to look at the tumor, use a small volume, and then you're able to do the control according to the intra-arterial injection. And then this is what Dr. Marco Menezes did, and we're starting to do this increasingly, even in renal lesions. And then over here we have the biopsy of the tumor, and the intra-arterial, you can see how it's exophytic and it goes to the central one, and it's not vascularized, and that's why it's not seen. And that's why we did not do the embolization. We wanted to do it, we thought it was not going to do it, and definitely this is the feeding branch, but it's very vascular, but it helped to describe the margins. This is the biopsy. And it also saved contrast because we did not do the pre and post venous injection. So there's a very small amount of contrast used. So first of all, we did cryoablation of the deepest part to be able to have less damage. And you can see that you have full ablation of the lesion. And then over here, the recent control, and then showing the clear cells and the resistance of the result of the ablation. So access complex as well. This was a child that had a venulolymphatic malformation that was retroocular, intraorbitary, and this is the contrast, and it's a lesion that has a venous and a lymphatic component. So in these cases, we've done bleomycin and the guided puncture, guided by ultrasound and fluoroscopy, and through the needle that was placed inside, I put a connector, and on the catheter, I can see that I had a drainage to the cavernous center, so I put micromoles over here that were still going through the coils over here, coils, and after that, so we injected. And then it's very easy for us to do this procedure. So to conclude, I think that this is going through a new era in terms of intervention. We can have the ideal situation, the ideal images, and we can do a correlation between angiography and a CT scan, and it's very safe for the patient, and then you treat the complications according to the diagnosis. You don't need to transfer this patient to another sector and waste time. You can associate vascular and non-vascular procedures, and this is pioneering, and we can develop develop new protocols that will maybe change our practice. And this also leads to empowering of the specialty with better results according to what is seen in other specialties. And I think we can show our relevance in multidisciplinary teams. Thank you.